Hello, welcome. Thank you for being here for this Sight and Sound Bites webinar today. My name is Kate Feibelman, and I'm the Senior Director of Development and Foundation Relations here at the Eye Foundation. And as you know, we put on these webinars a couple of times each month to discuss different topics related to hearing loss, head and neck cancer, vision loss, and other disorders. So we have an exciting timely topic for today's presentation, from evaluation and surgery to life with a cochlear implant. And our presenters today are Dr. Philip Perez and Dr. Kate Feibelman. As a quick reminder, we aren't using the chat function during the webinar, but we would love for our guests to submit questions at any point during the presentation, and you can do so in the Q&A box at the bottom of your screen. And once you ask them, I will kind of hold all the questions until the end of the presentation, and then I'll moderate a discussion with Dr. Perez and Dr. Feibelman. As always, there will be a video of today's webinar available on the Eye Foundation website. And if there are any questions that you have for either doctor that are more personal in nature, we typically don't read those live on the webinar, but we would be happy to send them to both of them and see if they can get you an answer related to your own personal health. So with that, I'll go ahead and introduce our speakers today. First, we have Dr. Kate Feibelman. Dr. Feibelman is a UPMC audiologist. Her primary interests include cochlear implant assessment and programming, diagnostic testing, and hearing aids. She's also a member of the American Speech Language Hearing Association and is licensed in the state of Pennsylvania. And then we have Dr. Philip Perez. Dr. Philip Perez subspecializes in otology and neurotology and treats the full range of otologic and neurotologic disorders with a clinical focus on cochlear implants and the treatment of vestibular schwannoma. Dr. Perez is also interested in health disparities in minority populations and is interested in expanding UPMC's outreach to underserved communities through work with local clinics like the Birmingham Free Clinic, and is a big part of our Mission of Mercy Pittsburgh every year. He also serves on the board of Pittsburgh Center for Hearing and Deaf Services and is co-medical director of the Western Pennsylvania Lions Hearing Foundation. So we have a great set of speakers for today. I can't wait to hear all of the updates that they have to share on cochlear implants. So with that, I guess I'm turning it over to Dr. Feibelman, and we'll see you later for questions.
All right, thank you for the introduction. So I am going to be talking about kicking us off with cochlear implant candidacy and evaluation in the early days with cochlear implants. So I'll start by talking a little bit about how we hear naturally or acoustic hearing in that pathway. So sound travels down the ear canal to the eardrum, which then vibrates the bones behind the eardrum and moves a fluid in the inner ear organ of hearing, or the cochlea. Inside of the inner ear organ of hearing, we have hair cells. So someone who has normal hair cells has pretty normal hearing, see here. And then someone who has hearing loss probably has some damage to those hair cells. When the hair cells are triggered, they send the signal to the auditory nerve, which then sends a signal to the brain that sound is occurring. And that happens much better when there's healthy hair cells versus some level of damage to the hair cells. So how do we treat hearing loss? There are a couple of different options when it comes to treating hearing loss associated with those hair cells, known as sensory neural hearing loss. The first step is typically hearing aids. So hearing aids do follow that same pathway that I just talked about, from the outer ear to the brain using those hair cells. But hearing aids are able to make the sound louder. So those hair cells, if they are damaged to a certain extent, hearing aids may not be enough. And that's how someone will typically reach the idea of a cochlear implant. They will try hearing aids to start, and then maybe for a few years, they're great. And then down the line, maybe hearing loss becomes worse and they explore more options. That could be either more powerful hearing aids or maybe a cochlear implant. So how is a cochlear implant different? Cochlear implant is not a hearing aid. It does not follow that same pathway that a hearing aid follows. It is a different type of hearing entirely. You could say that hearing aids follow acoustic hearing when cochlear implants use electric hearing. So there are two main parts to a cochlear implant. There is the internal piece, which is surgically implanted, and the external piece that sits on the ear, similar to a hearing aid. And together, those two pieces convert sound into electrical signals. It does not use the outer or middle ear like a hearing aid does. The surgically implanted piece takes the role of those damaged hair cells to send electrical signals to the hearing nerve. There's also a kind of combination device of these two types of hearing. There's the EAS or hybrid system. It uses electroacoustic stimulation to allow both natural hearing and electrical hearing to take place, which I will talk about in just a moment. But first, I'll talk a little bit more about how the cochlear implant processor works. There are two main styles of cochlear implant processors. There's the behind the ear style, which sits on the ear like a hearing aid, but there is an extra piece that sits up and back behind the ear to connect to the internal device that's surgically placed. And then there is the off the ear processor, which it works the exact same way, except everything is contained in the one smaller piece that sits right on that magnet site. So the way the device works, the microphones on the processor pick up sounds and convert them into a digital signal. The signal is then transferred to the implant just under the skin through that magnet connection, and the implant sends the digital sound signal to the electrode array that's surgically implanted into the cochlea, and then the hearing nerve can pick up the signals and send them to the brain where they are understood as sound. So back to that kind of combo device that I talked about. This is called a hybrid processor. So the main difference between this and the slide that I just showed and how the traditional cochlear implant processor works is that there's an additional piece called an acoustic component that sits down in the ear. So someone who has pretty good low frequency hearing, but maybe really significant hearing loss in the high pitches that a hearing aid cannot quite help anymore, this would be a great option for them. It's able to combine the use of a cochlear implant with those for the high frequencies, but also use the low frequency hearing. People who have this device tend to do very well. So how does someone get to the point of a cochlear implant evaluation? So typically they will go for their routine hearing test or routine hearing aid appointment where they will have a full hearing evaluation. So a little bit about the audiogram here. So across the top, we have the different pitches, low pitches, all the way to high pitches. And then along the side here, we have volume. So very soft to very loud. And in the middle here, you can see the thresholds are plotted. So the right ear is represented by the red circles, the left ear, the blue X's. The further down on the audiogram, the more significant the hearing loss is. This person has what I would describe as hearing in the normal range, sloping to profound hearing loss. And this is probably someone who potentially could be a good hybrid candidate for that combo device with their good low frequency hearing. A good way that audiologists know when to send someone for a cochlear implant evaluation is following something called the 60-60 rule. So the 60-60 rule follows looking at two different numbers or measures. The first is the PTA, or the pure tone average, and this looks at the threshold at 500 hertz, 1000 hertz, and 2000 hertz. It's looking for an average of 60 or higher. So hearing loss falls an average of 60 or greater. And then the second 60 in the 60-60 rule is word understanding. So when they are listening to the words in the hearing test, is their understanding worse than 60%? And this person meets the criteria for the 60-60 rule. So the pure tone average is worse than 60 in both ears, and the word understanding is worse than 60 as well. In addition to the hearing test and just knowing on paper if someone is a good referral, we also are listening to their complaints. Are their hearing aids not doing quite enough for them? Always asking for repetition even with hearing aids, maybe withdrawing from social situations. So all of that combined is a good way to look at if someone is a good referral for an evaluation. So what is the audiologist going to look at when someone comes in for a candidacy evaluation? We're looking for their thresholds, obviously, to fall within the range of the hearing loss that's significant enough for a cochlear implant. So for a traditional cochlear implant candidate, that would be this yellow image here, and then someone who is in the hybrid range, it would be this purple chart here. The second thing we're looking at is limited benefit with appropriately fit hearing aids, and we listen to what the patient has to say and then evaluate their hearing with the hearing aids in the booth with our testing. So what does the testing look like, or the appointment as a whole? It's a pretty long appointment. It can go about 2 hours typically. We start by evaluating hearing without hearing aids and then with hearing aids to measure sound detection. And then we do a lot of testing of speech understanding. So this on the right here is called the AZ Bio. This is a sentence list test. So we use this a lot in our testing. Listen to these sentences for quite a while. So we test this in a few different conditions. The first is with no background noise. The sentence plays, the patient repeats back what they hear with the hearing aids on. And then we do the exact same thing, but with a level of background noise. And then we do it again with more background noise. So for someone to be a candidate, they need scores to be below 60% on this part of the test for traditional candidacy. So we do that for the right ear and then the left ear, and then we do that with both ears together. So that's one part of the speech testing. The second part of the appointment is spent talking and counseling. So talking about expectations with cochlear implant, the risks and benefits, and then going over different devices. So we work with 3 cochlear implant manufacturers, Cochlear Americas, Advanced Bionics, and MED-EL. We talk about all 3 and let the patient decide which one is best for them. So I wanted to bring up an example of a candidacy evaluation on paper, a couple of examples here. On the right, you can see a very traditional cochlear implant candidate. This is actually a second side evaluation. So he already has a left ear cochlear implant and he was interested in a right ear. So first we measured his hearing thresholds. You can see at the bottom, he's got a severe to profound hearing loss. These are no responses to where he's not hearing even when it's turned up as loud as it can go. So he meets that criteria as far as where we need his thresholds to fall. And then the A's with the little R, those are his sound detection measures with a hearing aid. So you can see even with the hearing aid, he's still not detecting sound very well, especially in those high pitches, no responses at all. And this is a good example of what a hearing aid can do versus a cochlear implant. He's hearing sound across the board with his cochlear implant, even at a very soft level versus the hearing aid, which just doesn't have the capability of reaching that level. And then on the bottom here, you can see his word understanding scores or sentence understanding. So with no background noise, he only got 2% of the sentences correct. So he is a very clear candidate with scores below 60. On the left, there is a little bit of a different candidate. So she has good hearing in the very low pitches. It slopes to this profound high frequency hearing loss. And then with the hearing aids, you can see she does have some fair sound detection there, sloping to more of that profound loss even with the hearing aids. So it's not that she has no hearing. She does have a good bit of hearing. But then when we test her word understanding with the sentences, with no background noise, she is not a candidate. She is above that 60%. But when we turn on that background noise at a lower level, she falls below that 60% into the candidacy range, and even more so with more background noise. So what else are we looking at when it comes to determining candidacy? We are looking at hearing and hearing aid history. So somebody who is experiencing hearing loss as they get older and has consistently worn their hearing aids, their auditory pathway has been it's been utilized. So their brain is kind of ready for a different type of sound and for this change and ready for hearing, versus somebody who maybe hasn't heard in many, many years. Maybe they were born with a hearing loss and never wore hearing aids. A cochlear implant would be different for those 2 populations. We also look at cognition. Is somebody ready to work on what they need to do for a cochlear implant in terms of, auditory rehab? Are they cognitively able to take on this big change? That's a big piece of the puzzle. We look at support system. So having someone to support a patient as they go through this and help them through this big change, in addition to helping with auditory training and teaching their brain how to hear in this new way. A support system is a big part of that. Motivation is huge. So someone who is ready to wear this all day, every day, and put in the time and effort that is required to maximize potential with a cochlear implant. We look at overall health. Someone has to be able to undergo surgery safely. Appropriate expectations are a big one, which I will talk about in a second. And then a big thing to know is that health is more important than age. So between 2020 and 2024, the average age of our cochlear implant recipients was 63 years old, and at least 26 of the recipients were 80 years old or older. So age is just a number. A lot of things are taken into consideration, and age certainly does not count someone out. So some expectations: a cochlear implant can absolutely allow access to more sounds. And I pulled that same audiogram here to show what a hearing aid is able to do versus a cochlear implant. So sound detection is certainly better with a cochlear implant. And then it can also provide better clarity than with hearing aids. So with time and effort and putting in the work, which we talk about a lot, there's the possibility that understanding will be much better than with a hearing aid. And typically that's the case. A cochlear implant cannot repair permanently damaged hearing nerve or hair cells. It's a different type of hearing. Those hair cells are not being repaired. They're essentially being replaced by the surgically placed device. And some listening situations will still be challenging because the cochlear implant, though it's very advanced technology, it can't say what sounds are noise and what sounds are speech that someone really wants to hear. So some situations will still be challenging. There are different tools that we talk about that we can advise someone on to improve their listening in those situations, but nothing will be perfect. So activation day in the early days with a cochlear implant, everybody always wants to know, what does it sound like? There's no way that we can tell exactly what it will sound like for one person. I typically tell my patients that there is a spectrum of sound. On one end, someone may only hear like beeps and buzzes, something that maybe sounds like speech. On the other end, maybe it does sound more like normal speech with just a chipmunk sound quality. Most people fall somewhere in the middle of that spectrum. So activation day is the worst day as far as hearing goes. So even just between the beginning and the end of appointment, a lot of people will say, wow, it sounds so much better towards the end. So we're not super concerned with sound quality on day one. Our only goals of day one are to activate the CI and turn it on and have a basic idea of how the device works. So really simple. We talk a lot on that day about auditory training. So a cochlear implant takes a lot of work. It's a different type of hearing. You have to train your brain how to hear in this new way. It doesn't get turned on and automatically things sound perfect. It takes a lot of time and effort. So auditory training can look different for different people. Some people will use audiobooks and read along with the book in front of them. Others will use a workbook that's given to them by the manufacturer. It doesn't matter what method someone chooses, as long as they put in the time, wear the device, and are dedicated to their auditory training, they will be as successful as they can be. What about the other ear? So to be a cochlear implant candidate, you have to fall into candidacy for both ears. That doesn't mean that both ears will be implanted, especially not right away. If someone wears a hearing aid on the other ear, we typically recommend they continue on with that to keep their auditory pathway in use and ready in case they do decide to go for a cochlear implant, another one down the road. A lot of people stick with that setup. We call it bimodal hearing, with a hearing aid on one ear and a cochlear implant on the other. And a lot of people are very successful with that. So after activation, there are a lot of appointments in that first year. So we turn the cochlear implant on about a month after surgery, very basic programming on that day. About a month later, the patient comes back and we do a little bit more fine tuning, but still nothing too special. And then same thing, 3 months, 6 months, and then the year appointment, we do more programming. We call it mapping. The cochlear implant is what the programming, that's how we do that. And then we also measure outcomes at every appointment. So the patient would get back in the test booth and do those same tests that we did before the cochlear implant to track progress. The appointments are about an hour to 2 hours, depending on what the patient needs and what needs to be done. And after that year appointment, it's, maybe every year, every other year, the patient comes back. But no matter what, there's always continued support from the audiologist and, of course, the manufacturers. So I will pass it on over to Dr. Perez.
Thank you, Dr. Feibelman. That is a great discussion of who is a candidate for cochlear implant and what the process is like. And it's, it takes a village to have a successful plan for treating somebody's hearing loss with a cochlear implant. And so Dr. Feibelman and I, as well as two other audiologists that are dedicated to cochlear implantation within UPMC, work really closely, and it's a lot of shared decision making and a lot of helping patients through the process, because it's a big decision, a big step, but it's such an exciting thing to get to do for people, and it's really just an incredible aspect of modern medicine that this surgery works. It's just, we're very lucky that you can basically take a tiny wire and shock the hearing nerve, and the brain incredibly learns how to interpret that as intelligible speech. So we're very lucky that it works. It's just a really wonderful piece of technology that we can offer patients when the hearing is so poor that even a hearing aid is not helping with their nerve hearing loss. So I'll talk a little bit about the surgery, what that process is like. The cochlear implant surgery is it's an outpatient surgery, so you can go home the same day. But because you're under general anesthesia, you can't drive. You got to bring somebody with you who's going to take you home. But it's outpatient, so you go home the same day. You are under general anesthesia for about 3.5 hours is what I tell people. So breathing tube in, you don't feel anything, don't remember anything. And then it's about a week or two later, we bring you back to check the incision and make sure everything's healing up. But we wait usually about 1 month, 3 to 4 weeks of healing after the surgery before the device is activated or turned on for the first time with Dr. Feibelman and one of her partners. So what are the steps of the surgery? The cochlear implant is done with an incision that happens behind the ear. So we typically will shave a little bit of hair behind the ear. And some people make an incision that goes a little bit above the top of the ear, kind of into the hairline. Some people it curves right around here. But really our goal is to access the scalp underneath the skin, where we're going to place what we call the internal receiver, that part of the cochlear implant that has the magnet that attaches with the external magnet, and that also is processing those signals that then go down the wire. And the other part that we're accessing is the bone behind the ear called the masseter bone. So this is showing that incision that we make behind the ear. We create a pocket underneath the tight lining of the skull, underneath the scalp, where the device will sit. And then we're exposing this kind of triangle of bone to be able to drill through that bone and gain access to the inner ear. So this is a right ear. So we're seeing that external ear kind of folded forward. Up here is the top of the head, and down here are the feet. And the risks of the surgery are really informed by what are the other important structures we're drilling around. So this surgery is a lot of drilling using high-speed surgical drills that are actually adapted from dental drills. So the same, not quite the same drill, but the idea of getting your cavities drilled, we're using that to go through this bone behind the ear. And I call this surgery a hole within a hole within a hole, where we're creating deeper and deeper passageways to get to this tiny little access to the inner ear. And you saw in some of those diagrams the cochlea. The cochlea has a couple of chambers, fluid-filled chambers, that we're trying to access, where we can place the electrode and bypass those little cells that are no longer working to go straight to the hearing nerve. So we're trying to coil that electrode up around the inner ear. So we're drilling through these structures. We're avoiding the roof of the ear, which is the floor of the brain. We're avoiding the real big vein that drains blood from this side of the head. And then this is the bony ear canal that is kind of our third barrier there. And then we're getting down to this little triangle. So once we've drilled through this bone and gotten access to where we can actually insert the electrode, it's a very fine, delicate forceps are used to slowly insert this electrode into the cochlea. So we're coiling from the bottom turn, what we call the basal turn, up into this middle turn of the cochlea. And so you can see on this diagram, the schematic, there are these contact points. So the electrodes are running through this coated wire, essentially, and these contact points are then gaining access to the nerves of the inner ear that are in the middle of the cochlea. And so then when sound is turned into electrical signals, different pitches are stimulating different contact points. So some common questions for people who are considering the surgery. How do you know if you benefit from a cochlear implant? Dr. Feibelman covered a lot of that, but it's when you're getting to the point where your nerve hearing loss is so severe that even with hearing aids, you're not able to understand speech. And I talk to patients about kind of the Charlie Brown teacher voice effect, where you can tell that somebody's talking to you, but even with the hearing aid turning up the volume, the clarity of what they're saying is diminished. And so this is really meant to improve the clarity of speech understanding. It's like Dr. Feibelman said, sounds different for each patient, but it never sounds exactly like a natural acoustic ear, and it takes time for the brain to learn how to interpret those signals, and patients often describe the sounds becoming more natural sounding over time. Dr. Feibelman also covered this, but I get asked this almost every day. How do I know if I'm appropriate in terms of age or my overall health? And I operate on adults, so I don't treat children who are getting cochlear implants, but in adults, the most common patients are those who have had gradual hearing loss over time. In both ears, they've been using hearing aids. So it's a lot of our older populations, and it's people in their 80s and 90s who are undergoing the surgery and having years left to benefit from being able to hear their family again, being able to do the things they want to do, and benefit their overall health because of their ability to hear better. So how soon will I be able to hear? And that's a lot of the work that's done by the patient and by Dr. Feibelman and her colleagues who are working with programming and practice. But I tell people that it's, for many people, a full year of continued improvement, and there's room for improvement after that. But it's a long period of training the brain how to hear again with this device. So it takes patience, it takes practice, and then the programming sessions are done to adjust the settings of the stimulation of the device. And oftentimes patients will have preferred different programs, kind of like you may have used if you've had a hearing aid that has different settings. You can choose different settings of programs that slightly change how the device stimulates the inner ear. And what is the recovery from the surgery like? It fortunately is not a very painful surgery. So I tell people, plan to be taking it pretty easy for a week. You'll have a sore ear. We prescribe people stronger pain medication, but a lot of times they're using just Tylenol, and some people use no pain medication at all. So it's a sore ear, but it's for most people not an extremely painful surgery and relatively short recovery period. But we do wait that full 3 to 4 weeks after the surgery for some of the swelling to go down before we turn on the device for the first time. And then we talked a little bit about this, but how do you help somebody who has a cochlear implant be successful? And the people we see who do well are the ones who have support from family and friends. And so, if somebody in your life is thinking about this, go to that appointment with them. Be another set of ears to take in the information, to help encourage them through the process of, after you've gotten a cochlear implant, learning to hear and learning to rehabilitate your ability to do those things. So it definitely takes practice and patience, and having that strong support system really helps. So there are 3 companies that have approved devices for cochlear implants in the US. And as of July of 2022, there have been more than 1 million cochlear implants that have been done across the world. In the US, that's almost 120,000 in adults and 65,000 that have been done in children. So a common schedule for us here at UPMC is about 1 cochlear implant surgery a week. Dr. Feibelman is one of 3 really outstanding audiologists who are dedicated to cochlear implantation. and are, day in, day out seeing patients who've had a cochlear implant or who are considering that and going through this pretty extensive testing and counseling to see, is this appropriate, and do I have good understanding of, is this the right choice for me? So we have a great team, and it's something that draws people in from far and wide. And so one of the initiatives here is to help try to expand our ability to reach patients who are coming from far away. And is there a way that some of those appointments can be clustered together, so you get your testing, you see me, the surgeon, talk to them at the same time, you get your scans that look at the bones of hearing to help you prepare for the surgery and for us to know what your anatomy is like. You meet with the anesthesiology team to go over all your health history and talk about the risks of general anesthesia. So trying to cluster that in a convenient packaged appointment to limit, making trips from far and wide. And then, what is the role of, could there be programming that happens through teleaudiology? So could your audiologist be located in one place and you meet somebody closer to a satellite who can work with you after some of the initial setup to work on some of the programming? So it's an exciting time to be implanting cochlear implants, because they're expanding in what we can offer to different patients. So when cochlear implants were first approved, it was really for people who were had very poor hearing in both ears. And as time has gone on, we're finding that people with hearing that's not quite as severe still can be good candidates for cochlear implantation, where we look and see their performance and their satisfaction and quality of life with their hearing is improved at less and lower levels of hearing loss than we had previously said people were qualified to have a cochlear implant. So things that we talk about are how young, and so children ages 6 months and older can undergo cochlear implantation. And it's kind of an additional talk, but adults who have some of that residual hearing, and you saw that in some of the graphs that Dr. Feibelman was showing, where it's common that this type of nerve hearing loss affects the upper pitches more than the lower and middle pitches. So you can still have some ability to hear lower pitch sounds and still undergo cochlear implantation, or you can still have even at middle and upper pitches the ability to hear sounds, but that clarity is really reduced. And so more and more we're seeing people who we think will benefit and be successful with a cochlear implant who were considered to have too good of hearing maybe 10, 15 years ago. And then just in 2019, another candidacy criterion that was added on is something called single-sided deafness or asymmetric hearing. So it's the case where somebody could have normal hearing in one ear, but have deafness in the other ear, and could still be a candidate for a cochlear implant. And so the things we think about that helping with are really bringing kind of stereo hearing back to that person, helping with hearing in background noise. And so the expansion of that is basically letting people who didn't really have a good option for bringing hearing back to a deaf ear, even if they had a normal hearing, there's now the option of a cochlear implant. Some other things we talk about are hearing preservation. So when the electrode of the cochlear implant goes into the inner ear, there's inflammation and injury to the inner ear that for many patients means whatever hearing you had left in that ear is gone. But more and more we're finding that for some patients, we're able to preserve some of that natural acoustic hearing. And so if you can stimulate the inner ear with a cochlear implant, but still have the ability for sound to stimulate the inner ear as well, you can use that type of device that Dr. Feibelman showed, where it's both the electrical stimulation for the cochlear implant, but also a hearing aid that's really putting sound into that ear as well. We talked a little bit about stereo hearing and sound localization. Tinnitus is that name for ringing or buzzing or other sounds in the ears. And even though that's not unto itself a reason we do a cochlear implant, we are finding that that has a tendency to decrease the loudness of people's tinnitus. And then the other areas we talk about are music appreciation and how can people enjoy music and what type of music experience they have with a cochlear implant, where you're taking the natural ear that has 10,000 keys, collapsing that to 22 keys. It's never going to be the same, but how do we optimize people's ability to enjoy music? Okay, and next we have a special presentation before we go to our questions from someone you may recognize.
So I'm Elena LaQuatra, and I wear a cochlear implant in my left ear. So that's a reason I am so passionate about so many different causes that support the deaf and hard of hearing community and those who have cochlear implants specifically. I lost my hearing when I was 4 years old. I contracted bacterial meningitis, of course, very unexpectedly right after my 4th birthday. And my parents made the very tough decision. This was coming up on 30 years ago now, to get this new, at the time, cochlear implant technology. I went through the process of getting the surgery after I had healed from the meningitis and recovered from that. They put it in my left ear, and it was a blessing in disguise because I do so well with the cochlear implant. I just have the one in my left ear. And I went to the DePaul School for Hearing and Speech for about 3.5 years after receiving the implant. And that's where I learned how to speak again and how to communicate. From there, I mainstreamed into the Mount Lebanon School District and went about my years of schooling. And I eventually went to Point Park University, where I got my Bachelor of Arts degree in broadcast communications. And now I am a TV news anchor on Channel 4. Hopefully, you all watch Channel 4. I think undergoing any type of surgery would be intimidating and worrying, and definitely it's worth raising a lot of questions about. However, the doctors are so phenomenal and the surgeons, and this is such a simple procedure nowadays compared to even when I had it done 30 years ago, that they are so good at what they do, and the technology is incredible. The advancements in the technology is incredible, and it's really worth it to go through that process. The recovery process is a little bit of a process as well. Of course, you have to heal from the surgery, then you put the technology on your head, and you have to get used to it. Your brain has to adapt and how to listen in a whole new way that it never has before. I do, just from my personal experience, I can highly recommend seeking the specialty type of education that I think is necessary, like an oral deaf school where they specifically teach listening and spoken language skills. I think that's a big part of the process too. It's not just going through with the surgery and getting the implant, but it's the whole healing process, recovery process, and learning process after the fact that is important and crucial. I think also it's very helpful to just not only try to get as much information as possible and absorb all of that so you feel like you're going in there with a lot of knowledge, but I think it's also helpful to surround yourself with people who have been through this, people who, like me, who are on the other side of something that was so tragic and horrible and stressful for my parents. And obviously I do so well with it that I couldn't imagine my life without it. I think hearing those stories and talking to those types of people can really help and maybe put your mind at ease. I think in having the cochlear implant, there's challenges with living with any type of disability. For me, they seemed very minor throughout my whole life, and still to this day, I don't look back thinking I missed out on anything because I have the implant or because I'm deaf. Like I said, I maybe was never the best singer. Maybe if I didn't lose my hearing, I would have been. I take it off when I am in water, so swimming in the ocean, at the beach. I'm cautious of it, obviously, in the shower. I couldn't imagine my life without it. I will certainly say that it is such a blessing to me. my career, the things I've done in my life, the things I've accomplished, just every aspect of my life would not have been possible without my cochlear implant. So I'm very grateful for it. For my surgeon, Dr. Kammerer, every time I say his name, I start crying. So I have to just kind of keep it quick when I talk about him, because he changed my life so much, so many times over for the better.
I think with that, we'll end on that really moving, inspirational message from Elena LaQuatra. Elena is so active in the community and in so many organizations, the Eye and Ear Foundation being one of them. She sits on the Eye and Ear Foundation Board of Directors. I know she's also very involved with the DePaul School over in Shadyside. She's an alum from there. And we're so happy to have her in Pittsburgh, kind of bringing awareness to cochlear implant technology and to any kind of hearing related disorder. And she's just really a delight to be around. And we love seeing her on the news every day. So thank you to Emily and Kate. Thank you to Dr. Perez, and thank you to Elena. So I think with that, we'll go ahead and get our question and answer portion started. We have many questions. I will say that I don't know that we'll be able to get through all of them. So if there are some that are more personal in nature, we will send those over to Dr. Feibelman, Dr. Perez, and get you answers personally sent to your email. So not to worry if we don't get them to them live. But one question I know that a lot of people who are just curious about cochlear implants have, and those who are considering, getting them, are why can there be such a variation in the hearing ability between patients, like who get cochlear implants? Some people seem to do really well, some people seem to not do well. You kind of touched on this, but could you delve into that a little bit further?
Sure, I'll take this one. So I mentioned that there are some considerations we take when we're looking at candidacy. I think the biggest one here is their hearing history. If someone has slowly lost their hearing over time, but they've worn their hearing aids consistently, their auditory pathway is going to be a little bit stronger. It'll be ready for that new stimulation. So the sound isn't totally new, it's just different. So they're hearing, but they're hearing in a different way. So versus somebody who has never heard before. Kind of like if you try to learn a new language, if you stop practicing, you forget it. But if you keep practicing, it's always kind of there. So kind of the same thing with hearing. So a lot of factors come into what level of success someone will have, but I think hearing history and hearing aid history is a really big one.
Yeah, it's I always tell patients hearing starts in the ear, but so much processing happens in the brain. So we like if somebody has been wearing hearing aids, even though they're struggling to hear well with a hearing aid, but they've continued to use a hearing aid and to stimulate all the auditory centers of the brain to keep those connections strong. That helps improve the success that they'll have with a cochlear implant. But it's actually a really important area of research to figure out who is going to do very well and maybe who will not do as well. And it is true that there are some variations that are hard to predict and we don't have a good sense of. Fortunately, where we're setting the bar for whom we deem with testing to be a candidate, the vast majority of people benefit significantly. And it's just a very high chance of getting access to sound, but how clear the words become and over what time frame can really vary. So one example of all those connections to the brain is that we see some patients who've had sudden hearing loss, and the common cause of that is a viral infection of the hearing nerve, we think, on one side. And people who get a cochlear implant soon after they lost their hearing, but just before that had pretty normal hearing, are some of the people who do really well. You turn on the device and some of them are understanding speech that you're saying to them right away. So those connections to the brain are important. And then the practice and patience using the device are really important as well.
Great, thank you. There are a few questions here related to the coverage of this procedure and the ongoing maintenance care. Are cochlear implants typically covered by insurance? or are they more of an out-of-pocket expense?
Yeah, so they typically are covered by insurance, and when you go through the testing, and that it's pretty extensive testing, as Dr. Feibelman explained, but part of that is showing to the insurance company that the hearing is bad enough that a hearing aid is not going to be helpful for that person's hearing to the degree that we want. And so the process for that is once we're considering a cochlear implant surgery, we send all the information to the insurance company and get something called a pre-authorization, where they say, yes, we agree this is appropriate and we'll cover the cost of surgery under your insurance policy. What's trickier is we mentioned when it's single side deafness, there's only one ear. The coverage by insurance for that is a little bit more spotty. So sometimes that involves writing letters to the insurance company, going through appeals to try to get them to see the benefit of that and agree to pay for that.
Helena, in her remarks, mentioned attending the DePaul school. Are these types of specialty schools financially covered for patients? Are they low-cost options? Or do you know anything about like the structure of the school and how they work with families?
You know, I'm not sure about the DePaul school for certain. I know there are people I see in the chat who will know for sure the answer to that, but no, I don't know the specifics of how you apply to be in that school and decide where you're going to be for that.
Well, thank you. And there are a lot of resources directly at the DePaul school. So anyone that has a question about how they accept students and how they, work with families to, for that payment, I would encourage you to seek them out. They're a great resource, a great place. Cochlear implant surgery is very complex, and you're very subspecialized in what you do, Dr. Perez and Dr. Feibelman, in your realm of audiology. So is this procedure only done at large hospital systems? Are there other regional hospitals like Erie and, some of the more community-based hospitals? Do they do them, or are most people referred here into Pittsburgh that are seeking out this treatment?
It tends to be more centralized. So I do not think there's anyone in Erie right now doing cochlear implants, because we see a fair number of patients who come from Erie. That being said, the expansion of, I tell patients that my job's kind of the easy part. I'm the technician to just put in the hardware, and a lot of the work is done with our cochlear implant audiologist. So, in theory, some of that programming can be expanded by audiology covering broader regions, and that's one of the initiatives that we're working on, because we get that it's tough for patients to have to travel a far distance. So, but it does tend to be centralized, and most of the surgeons who do this are not general ENTs. They have gone through specialized training in ear surgery, or either with a 1 or 2 year fellowship training after their 5-year ENT residency to specialize in cochlear implant surgery.
The surgery now, what Dr. Perez was saying, is very central. We are working on expanding where patients can go for their follow-up cochlear implant programming. So that'll make it hopefully a little bit more accessible to people. Right now, it's just Oakland and Johnstown, but we are working on expanding that a little bit.
So looking at this issue from the front end, if someone is living perhaps in a rural area in a community that may not be so close to Pittsburgh, but close enough if they needed to come eventually for surgery, where would they start their process? Could they be seen by a local audiologist and then referred? How does that kind of pathway look for someone who might be living in a rural area?
So I think they'd probably either see an ENT or an audiologist first, and hopefully one of them would say, based on that 60-60 rule I brought up, hopefully they would kind of think this person could be a good cochlear implant candidate, and then send them our way based off of that. And we try to do those appointments the same day to see audiology to formally determine candidacy, and then see Dr. Perez on the same day to talk to him about surgery and all of his pieces of the puzzle.
Yeah, I agree. That's kind of a good rule of thumb is there are lots of audiologists who don't specialize in cochlear implantation, but who can measure the hearing and have a sense that somebody could be a candidate. So there are people who you test and you know for sure they're not in the area where you'd really be thinking about that. You'd say, let's go the hearing aid route. And then there are people who, based on their hearing test, just have a really high chance of being candidates. And then somewhere in the middle or the gray zone where it's a decision-making process. But that seeing an audiologist closer to home and having that sense can then be the impetus to come on and see us for the specialized testing with Dr. Feibelman and her counterparts.
So here's a question, and this is something I've wondered about too. So if a person is considering this surgery, this technology, and they still have some hearing loss that they maintain, like in a tone range, after surgery, can you still maintain that same hearing, the hearing that you retained, or is the hearing completely taken over by the cochlear implant?
We hope and always try to preserve what hearing people have left, but I always prepare people to lose that residual hearing. So I tell people for most patients, it's kind of a one-way street where you can't go back to a hearing aid because the device going in the inner ear causes you to lose the residual hearing. That being said, it is our goal to do the surgery as gently as possible as we place that electrode. And we do have patients for whom they have almost all of the hearing that they had before after. Over time, some of those people who still have that hearing immediately after surgery can tend to lose their hearing. There's some recent studies that have looked at why that may be, and it's kind of like your body not liking something that doesn't belong there. There's inflammation and reaction that down the road you can end up losing that hearing, but it is possible. And so we call that hearing preservation cochlear implantation, where we try to save the residual acoustic hearing. Many patients, there's really not much hearing left, but for those who do have, especially that lower frequency hearing, if we can save it, it's helpful for their hearing.
So one benefit of speaking with both you, Dr. Perez and Dr. Feibelman, you go to meetings and conferences all over the country, all over the world, and you hear about, new advances, new technologies. Can you share or discuss any potential new developments in cochlear implant technology that might be on the horizon?
Well, it's interesting. You saw that diagram of the contact points. And we talked about taking the keyboard from 10,000 keys to 22. Right now, there's kind of a size limitation on how many different points along the inner ear can you stimulate that. What you'd really like to see is, could you expand that or come up with different programming of even what you have that can kind of fine tune the stimulation you can give to the inner ear. But there's a little bit of a plateau right now in terms of the technology. There are some companies actually based in Pittsburgh who are looking at, with special attention to how do we save that hearing, ways that you can get just a very gentle, trauma-free insertion in the inner ear. So there's a company that is using a robotic attachment, and they're started in Iowa, but they're now based here in Pittsburgh. There's another company that is developing a tiny little strand that goes on the electrode itself, and you can get feedback of the sensor. And so you could say, we know where exactly in the inner ear this is. We know if there's bending or resistance that can help adjust the insertion. So those are some of the developments. And then other people are looking at, could you stimulate the inner ear in other ways? So could you, for example, use light to stimulate the inner ear to get more contact points. But those are some of the areas with cochlear implantation. But Dr. Feibelman showed the picture of the hair cells that aren't working. There are also some really incredible researchers within the University of Pittsburgh who are looking at, can you even rebuild some of those cells, get them to grow back? So it's a very active area of research in Pittsburgh. We're lucky to have some incredible researchers here on the hearing side that are really pushing the envelope.
Not quite as exciting as what Dr. Perez is talking about, but I think what a lot of audiologists are excited about is opening candidacy up a little bit more. And just, the single-sided hearing loss, like Dr. Perez was talking about, and asymmetric hearing loss. So I think that's what a lot of audiologists are excited about, because those are some really amazing cases when someone lost their hearing, not too long ago, and you turn it on, and I've had some people who they say, yeah, it sounds pretty normal. And it's just kind of incredible because it's never what we expect, but it's always amazing.
Well, thank you. It sounds very exciting for the future, and it sounds like Pittsburgh is going to be the place to be for anybody who is kind of wondering about this technology and other treatments for hearing loss in the coming years. So we're very excited about that. Final question, and you may have talked about a little bit about this, but we'll just end on this. If hearing loss is in both ears, if it's dual-sided hearing loss, do people get both ears implanted or just one ear? Or is that just a case-by-case basis?
I think it depends on the patient. A lot of people, if they're a candidate in both ears, like a traditional candidate would be, they'll get the one cochlear implant, and then maybe they won't get another one, and they're happy with their what we call bimodal setup of a cochlear implant in one ear and a hearing aid in the other. Then maybe they love their cochlear implant so much they want another one. So in a year or maybe 2 years, possibly many years after, they could get a second one. So definitely both are options depending on the patient, their situation, but they could do one or they could do both.
Yeah, and I tell people there are pros and cons to going to 2 cochlear implants or having one, even if it's a poor hearing ear, one that could still have some natural sound. So it's definitely a very personalized decision. Takes a lot of discussion and thought. And I see lots of people who are happy with one cochlear implant and other people who are really pleased they decided to get a second cochlear implant. So,
well, I think with that, we're right about at 1 o'clock, and I want to thank all the attendees today who spent their lunch hour with us learning about cochlear implants. I want to thank you, Dr. Perez, Dr. Feibelman, so very much for spending time talking about this important subject. I know there are a lot of people out there who are considering this option and may need to know more about it. So we appreciate you taking the time, and I want to wish everyone a happy Thursday afternoon. And again, there will be a video recording of this webinar available on our website in a day or two. So thank you to all.